Good evening, everybody. Welcome to our Facebook Live presentation tonight. I'm Dr. Eileen West. I'm a general internist in Fairfax, Virginia, and I am so excited to be introduced to introduce you to my friend and colleague, Dr. Rachel Rubin, who is a board-certified urologist and sexual medicine specialist. And she is our guest tonight for Ask the Expert, learning about aging and sexual health. Welcome. How are you, Dr. Rubin?
It's so Thank you. I'm so happy to be here. I'm thrilled. I'm a big fan of Ms. Medicine and everything you guys are doing to support primary care and women's health. And just thrilled to be here and hope your audience enjoys.
Well, I am so fortunate to have you in my backyard and to get to see you regularly. It's really wonderful through the different organizations that we're part of, and just so excited to have you here. So, well, I would like to go ahead and formally introduce you, and then we're going to dive right in on tonight's topic, which is bound to be a good one. And we really want you to be able to think up some great questions for the viewers out there. Please remember that you can put comments in the chat. We will be following along as we go, and we are eager to answer your questions. And we're looking forward to spending the next hour or so with you tonight. So, all right, Dr. Rachel Rubin is board-certified urologist and sexual medicine specialist. She is one of only a handful of physicians with fellowship training in sexual medicine for all genders. Dr. Rubin is a clinician, researcher, and passionate educator. In addition to being education chair for the International Society for the Study of Women's Sexual Health, affectionately referred to as ISWISH, she serves as an associate editor for the journal Sexual Medicine Reviews. Dr. Rubin completed her medical education at Tufts University, her urology training at Georgetown University, and her sexual medicine fellowship training with Dr. Irwin Goldstein in San Diego, California. So without further ado, let's just jump right in and let's talk about sexual health and aging. I know this is a huge topic for many people who really want to make sure that they are living life to the fullest. And sooner or later, this is a topic that's going to come up, and there may be problems that arise. And fortunately, we have somebody here who can help us with solutions. So let's go ahead and put everything out on the table. Feel free to answer any questions that you have, and to ask any questions that you have, and we'll do our best to answer them. What is it that you would like to know? So let's go ahead and start with what your thoughts are, Dr. Rubin, about how people can continue to have a healthy sex life well into old age.
Yeah, so I think, age is just a number, right? You can be an old 60 or a young 60. You can be a young 95. You can be an old 95. Age is really just a number. And I believe with how you have sex as a young person can be a big predictor in how you have sex as an older person. If you're phoning it in and having mercy sex or duty sex at 30 and 40, it's unlikely that you're going to have wild, amazing sex in your 80s and 90s, although it is possible. There is never a time where you can't have good sex and great sex. I think the thing about sex is that it looks different for absolutely everybody. And we think we know what it looks like for everybody else. But in fact, we have no idea, nor is it any of our business what kind of sex other people are having. The only thing that matters is what you want and what you and your partner want or partners want. And it's about that communication and figuring out, well, this is about pleasure and playtime. What does it look like? And am I getting pleasure? Am I getting joy out of it? And so as we age, a lot of things can change, just like you can get high blood pressure and diabetes. That can affect erection health, that can affect your libido, your arousal, your ability to orgasm. But we really look at this in what's called a biopsychosocial way, which means that there are a lot of biological things that we can do to help you, but there's also a lot of psychosocial things that we can do just to get your mindset around having better and a more enjoyable time with you by yourself or with your partner.
And all of those components, I think, really factor into it. There are so many different things that go into building a good sexual experience and good healthy sex life, including interest. The interest in sex comes from there's so many factors. So it can be hard sometimes to tease out where the problems might lie. But that's really wonderful when we have different types of specialists who can help out with it. So
I think the key is again, doctors don't often ask about your sexual health. I've certainly never been asked by a doctor about my sexual health, and they all know what I do for a living. I'm a sex doctor, for goodness sake. And so we think of sex as magic and not medicine and biology, but really sex is biology and physiology, and it's together in a coupled way. Sometimes it doesn't always have to be. And so we forget that it's medicine. And so we don't show up to the doctor to say, hey, doc, men do a little bit more. They say, hey, doc, my erections are not so good, or my orgasm has changed, or, I'd like something to be better. Women don't always do that. They sort of show up for good enough, right? Good enough. Like if they're having good enough sex, they don't talk about it. If they're having pain, sometimes they'll come in, and then you're like, well, not only does it not have to hurt, but we can actually help you enjoy it even more. We can actually make you, you can get to the point where you might actually want it or choose to have sex. That's mind blowing for many women, of like, they don't even, they want the bare minimum of, I just don't want it to hurt anymore. And they don't realize that there's so much more that we can do.
Yeah, and that's a good place to start. Let's go ahead and start, because one of the most common issues that I hear about are when it's uncomfortable. It stops being comfortable to have sex. So what is that all about?
Yeah, the most common reason why sex is uncomfortable is actually a hormone problem. So the genitals are extremely hormone sensitive structures. The vulva, the vagina, the penis, the testicles, they're very hormone sensitive. And so when you're a baby, right, the genitals look one way, and then you go through puberty and you get this surge of hormones and the genitals grow and change. And then as you get older, sometimes when you lose hormones, especially for women who lose their hormones in menopause, the tissue actually sort of shrivels up in a way. It gets thin, it gets raw, it gets irritated. It's used to having hormones around. And so what happens to the tissue is it gets dry, it gets irritated. And so you get genital symptoms like pain with sex or dryness. You sometimes get extra vaginal infections and things like that. But you actually get a lot of urinary and bladder symptoms like frequency and urgency, and recurrent urinary tract infections, which can be quite dangerous. And so this is something we refer to as genitourinary syndrome of menopause. And it's really the number one reason for anyone over 40 who has pain with intercourse. It's likely genitourinary syndrome of menopause. And it is so easy to treat. It is so rewarding to treat. We can make all that pain go away. And not only does it make the pain go away, it helps with lubrication, it helps with arousal, it helps with orgasm, it helps to prevent urinary tract infections. So here you have literally something that's like Lady Viagra, right? It helps with the swelling of the genitals and arousing of the genitals. It's basically Viagra. And it prevents UTIs. Like Viagra doesn't do that. It doesn't prevent UTIs. So how cool we have something that is like Lady Viagra. And the crazy thing is, Dr. West, is it's been around since the 70s. We have had vaginal hormone products since the 1970s. And yet women are not being given this often. I know in your practice, of course they are, but women are not being given this as an option because we as a society do not like talking about women's sexual health. And the urologists don't enough talk about bladder health. And so we're sort of starting from scratch here, which is very frustrating.
Well, it really is. And I'm always disappointed when I encounter even other physicians and providers who really just have never been exposed to a whole lot of training or information about menopause. And so they just aren't comfortable often having these conversations or providing solutions to people because they haven't been trained. And that's one of the things that we're really eager to try to change with Miss Medicine. And we have, active educational sessions for any provider who wants to participate on Monday evenings. The case conferences are terrific. And you can just go over to the missmedicine.com website and under education and learn about those programs and sign up to participate in them.
There's going to be an incredible one this upcoming Monday night, all about vaginal hormones, what I was just talking about, and how they're safe for pretty much every woman, breast cancer patients, patients of all ages, people with a history of blood clots. They are so safe. And so there's a couple leading experts who are going to be talking on Monday. And I certainly really don't want to miss that. It's going to be really fabulous.
Me too. I think it's going to be great. And I would say that that is one of the conversations that I have most often with my patients, because hormones have had such a bad rap for so long. And it's really, I think one of the best things we can do is help people to understand that topical vaginal estrogen in the low doses that we use really are safe and effective. As I understand it, they're basically safe for pretty much everybody.
Everyone. There is nobody on earth who I think is a true contraindication. Now, there's patients I'll have extra conversations, and I might pick up the phone and talk to their oncologist if for nuanced conversations. And there are patients who are just too fearful, even though estrogen does not cause breast cancer, right? There's nuances in this hormone story that it doesn't make for good headlines. But vaginal hormones, local hormones, are totally safe. They are. There is not any data at all to show danger, which is what's so crazy. Is we've got data to show that sugary drinks cause harm, that alcohol causes harm, that excess weight causes harm, that smoking causes harm. There is no data on earth to show that local vaginal hormones cause harm, and yet they cause UTI prevention. They help with sex be more comfortable. They're literally safe for everybody. And yet so few women are even being offered this magical therapy.
Yeah. I've heard you say before that pretty much every woman over the age of 50 should be on vaginal hormones.
I'm a big believer, right? Like, we moisturize our face, we brush our teeth every day. Like, why wouldn't we put hormones in our vaginas to keep it strong and healthy and prevent bad things from happening?
Because we know there's just such a decline as women's ovarian function goes down. There's just, everything about that region of the body changes, And so, so tell me a little bit about, with some of the hormone treatments, have you found that you can really, I think in your line of work, you probably see not only just improvement with discomfort with sex, but also the correction of some pretty significant medical issues like lichen planus and some of these lichen sclerosis, some of these other conditions that really cause problems for women down the road, in addition to, as you mentioned, the urinary tract.
Yeah, it's incredible, again, how easy a local therapy is to fix chronic yeast infections. Chronic bacterial vaginosis, lichen sclerosis, is often mismanaged by just giving someone steroids, and they should be on vaginal hormones as a baseline. And honestly, the urinary symptoms, I can't even get urologists to understand it. We fix frequency and urgency. And I had a woman just today who said, gosh, Dr. Rubin, my leakage is better, right? I'm not leaking as much. And so it's really, it's so easy. And yet it's so underused and under talked about. And this is lifelong therapy. This is not something like, this is something 98-year-old grandma should be on to prevent urinary tract infections. And so it's really important that we understand that it's actually not about sex. It will make it so you can have sex if you want penetration to be as part of your toolbox. But it's funny because I'm a sex doctor. I love talking about sexual health and all fun ways to have a good sex. But I actually find this is actually more about bladder health. Has nothing to do with sex. Like, I want you to use this regardless of if you are sexually active. And so I don't want you in the nursing home at 98 with a urinary tract infection. Like, that's what I'm trying to prevent. And that's what I'm thinking about. And it's very easy. I like estradiol vaginal inserts, small tablets. If you ever follow me on social media, I will tell you exactly which dose and which medication. There are creams. There are vaginal rings you can put in. There are even non-estrogen products like vaginal DHEA, which is quite useful and a nice product. So there's quite a few options out there. And some of them are even affordable nowadays, which is very exciting.
Yeah, no, it's really nice to see some of the price come down on some of the options. And it is helpful to have choices. I think people, there are all kinds of different ways to deliver those hormones, right?
I think a lot of time people are giving creams, and a lot of women do not like messy, goopy creams that can kind of leak on things. And so they stop it. They try it for 2 weeks. It takes about 2 to 3 months to start working. And so they try it and they say, oh, well, I tried it for a month and I don't notice a difference. And like, it's kind of goopy, so I'm just not going to refill it. And it will not start working for about 2 to 3 months because it takes time for the tissue to heal itself. It takes about 2 to 3 months. And so it's really important that we educate patients to understand that it takes time. You can't try it for 2 weeks and say, oh, it didn't work, now let me try something else. You have to use this as the foundational sort of building blocks for the tissue. And then you can try other things. There's lots of other things to do for this as well. But it's really important to get that foundational treatment to the tissue.
Yeah. Yeah. I had an experience recently where it was impossible to actually collect a pap smear on a patient because there was so much discomfort. And 1 month after using a little bit of vaginal estrogen tablets, easy peasy. It just was not a difficult exam anymore. And I think that it has a lot of influence in people's lives, and that's a real
women often would rather suffer than, talk about vaginas to their doctors. I mean, it's mortifying for many patients to bring it up. And that's what the research shows, is that patients do not bring it up because they assume, they don't think the doctors want to hear about their vaginal dryness or their discomfort or their leakage, right? And so they talk about their diabetes and their high blood pressure. And so it's really important for your doctor to bring it up and for us to educate doctors about how this is more than just, this is quality of life, but it's more than quality of life. It's about preventing urinary tract infections and allowing women to sit and wear pants and move in the world. And that's the messaging that I think is missed out there.
Yeah. And I think it's important to recognize too that the guidelines changed in 2020. The new updates that have now strongly urged this for multiple specialties to consider, to ask, and to treat for these problems. It's finally becoming a little bit more standard of care, which is really wonderful. And I will say the last 3 times that I've called to talk with an oncologist about a patient who may recently have, come through treatment and management of breast cancer, or, the oncologist, each of those 3 times has been A-okay with using the hormones.
Yeah, it depends on where you are in the country. We still have pockets where it takes a long time to make change, but we're screaming loudly and we're getting information across. And I will say social media has been extremely helpful to change that messaging. And we've been working hard. The American Urologic Association has just agreed to do guidelines in this very issue. And so that will be a huge movement in getting this to be more standard of care for generalists out there. So I'm very excited about that.
That's great. You told us when you'd had a Twitter post that went viral that really was about this, wasn't it?
We've had a number of Twitter posts go viral, and my co-fellow Ashley Winter and I both tweet constantly about vaginal hormones and vaginal estrogen to the point where we've got Mark Cuban listening. We've got, internists in England listening. We've got all these people listening and finding, because we're really teaching. I've gotten into trade journals of emergency medicine. I've been on we're getting emergency medicine doctors to consider prescribing it from the ER. Like, we're really social media has really allowed for us to disseminate information quite widely. So, one of my Twitter threads on this, which is always at the top of my Twitter, I think 250,000 people have seen that thread. And that's really what is so cool, is that we can teach these very simple concepts that are so unbelievably helpful to women, and we can teach medical students and interns and residents and practicing physicians, because at their institutions they don't always have anyone leading the way and showing them how to do this. And if someone doesn't show you how to do something, it's really hard to make those moves and actually know how to counsel someone properly.
So what do you tell your patients when you're counseling them about how to use this vaginal estrogen?
Yeah, so I like using estradiol tablet inserts. They're like 10 microgram inserts. I had several patients today I work at the VA hospital on Wednesdays, and I said, here's a tablet. You're going to put it in every day for 2 weeks and then twice a week till death do you part. It is going to acidify your vagina. It's going to fix the microbiome so that the tissue becomes strong and healthy and can fight infection. And it's really important that you take it just like you moisturize your face, just like you wear your seatbelt. You're never going to stop doing those things. And so this is now, very similar to those things. And it's just now a part of your routine. And I want to see you back in about 2 months to show you how much better things look, how much better they feel, and they become believers. It really doesn't take a long time to really just spend that time educating them about why it works. And I'll even I had a lady today, I showed her that whole Twitter thread. I just went through it with her. I said, this is why you're having bad, she was having a urine odor and a frequency and urgency that was new after her hysterectomy. And, she'd been swabbed, she'd had all these cultures, everything was negative, but she's having hot flashes and she's having night sweats and all of these things. And I said, all right, let me show you this Twitter thread. She's a PhD doctoral student. And I take her through this Twitter thread. I just read it to her and she's like, well, crap, I understand that. That makes perfect sense to me. She totally on board. And we had a plan, and to understand why, things were happening. So I think, for me, I'm a big believer. It's the education piece. Like, people have to understand why they're doing something. And when they understand that, then they're going to stick to it and stay on, and understand why they're doing it.
Yeah, no, that's terrific. All right. What other kinds of problems do you think people encounter? What do you see frequently in your practice as other sexual health kinds of topics and issues that come up?
Yeah, we see a lot of pain. We see a lot of low libido, right? So low libido is for all genders. I see low libido, women with low libido, men with low libido. And so we look at libido from a very biopsychosocial framework, which means you got to get to know someone, right? I love my practice because I spend, a very long time with people, really getting to know them, asking them questions, finding out about their lives. I have to know about their medical history and their surgical history and their medications. All of that can play a role in low libido. And then you got to learn about their relationships and how they were raised thinking about sex and what kind of sex they're having, what kind of sex they want to have. And so when you treat libido, you have to get to know someone so that way you can have a good idea of what makes sense. And that may be education. It may be, sex therapy. It may be, just finding new ways to have more fun in the bedroom. But it also might be something that's a hormone. It may be something that's a non-hormone, but we have quite a few medications available to help with libido. We know menopause hormone replacement therapy can be very helpful for libido, and that's estrogen as well as testosterone can be extremely helpful. We've got great guidelines on that. And then there are non-hormonal treatments for low libido. We actually have 2 FDA-approved options for low libido. And when they work, and they work in about 50 to 60% of people who take it, they work awesome. I got this incredible email just this morning from a patient who took one of the medication and said, holy crap, Dr. Rubin, I just had the best sex of my life. I feel like a teenager. And so this idea that sexual health and libido are not biologically based is ridiculous. Like, horny teenagers do not have deep, meaningful conversations. Like, they're hormonal, right? So there is biology, there is dopamine, there is underlying. That doesn't change the fact that, yes, you need to have, you need to feel safe and you need to have deep, meaningful conversations and have some excitement. But that's why it's what we call biopsychosocial. And so we really believe in that and have great results with our patients.
That's wonderful. That's really terrific. And so you mentioned that there are 2 products that women can take. And of course, we know about some of the products that are available for men. And you manage all genders, right?
Yeah.
So
yeah, and we often will use off-label medications for both genders. We have fun. We give women Viagra and Cialis sometimes when we need to increase blood flow, and we give men some low libido drugs that are approved for women, and they work, right? They're not gendered medications. And so I actually find that my work as a urologist actually helps me because I know how to treat everybody. So I take what I know about men's sexual health, which were about 20 years, ahead, in men's sexual health. And I sort of translated into what we know about women's sexual health. And then we go from there. And we have several options for women's sexual health, right? These 2 FDA approved medications for low libido, they work great. So if you think of the way I explain it, right? If anybody watching knows that antidepressants can cause sexual side effects. If you don't know that, you're very lucky. But anyone who takes an antidepressant sometimes will complain of low libido and delayed orgasm. Whether you're any gender, you may have that as a side effect. And of course, being depressed or anxious is not very sexy either. So we always have to weigh the pros and cons when we start medications with patients. And so if we know that there's medications that cause sexual problems, well, could there be medications that could boost sexual function? Of course, right? You just do the opposite and you kind of boost the other receptors. And there are 2 FDA approved options to boost those receptors. Just like Prozac doesn't work in everybody who takes it, neither do these medications. But oh my gosh, when they work, it's incredible. I had a patient just the other day. She's a physician, she's a colleague, and she had been breastfeeding for a really long time. And so she had some dryness and pain, similar to genitourinary syndrome of menopause. We gave her vaginal hormones, and also she was having some low libido issues. So we started this medication called ADDY, ADDYI, and usually it takes about 2 to 3 months to start working, sometimes 1 to 2 months. So I saw her at 1 month, and she sat there. She said, "Rubin, it's all better. Everything's better." In 1 month, she said, this is a physician, right? This is a smart lady who truly understands how this all works. She said, "Holy crap, it's not painful anymore." And the way she described her libido, she said, "Rubin, the net and the ball are just meeting each other so much more. I'm not missing, we're not missing." And it was such a perfect analogy of just it works, right? Not only is it not painful, but I actually want it. I'm interested. I'm responsive to my partner. And I did nothing for her psychosocial relationship. She's in a happy marriage. She loves her partner. She's so excited. And yet the libido thing was really kind of dragging her down. She was bothered by it. So we started this medication. The side effect profile is very kind. It is not a scary medication that causes a major harm. And it works. When it works great. And so the other patient that just emailed me this morning had tried this medicine called Vyleesi. It's an injectable that you inject it in your leg about an hour before you want, and you get a hit of dopamine. And this is a woman who is a high-level professional in the field who understands the psychosocial world quite well, and said, "Holy crap, Rubin, you hit it out of the park. I was a horny teenager. This was the best sex of my life. I did no psychosocial intervention." Now, that's not to say that you can't make enormous strides with psychosocial interventions and therapy and learning about sex and having better sex, right? That's really the key is the sex that you don't, is the sex that you're having even worth wanting, right? I talked to a woman today. She said sex was painful. She's never had an orgasm. She's dry. She's uncomfortable. She's on an antidepressant. She's menopausal. And she's like, "Well, I don't want sex." I said, "Well, no shit, you don't want sex. Why would you want sex? You're not getting anything out of it. You're not having pleasure. You're not having orgasms. You're not interested. You're on an antidepressant that makes you not interested. You have no testosterone or estrogen in your body to make you not interested. Give yourself a break," right? We have this idea that we should all want all the time. That's ridiculous. And so it's a lot of education and really getting to know people to say, well, here are the things that we can try, and let's tinker a little bit. Let's have some fun and play.
Mm-hmm. Yeah, that's great. Let's talk a little bit about testosterone. You mentioned testosterone as well as an option for some people. And I know that there's been a lot of interest and recent updates to guidelines about testosterone. And it's both for use in men and for women. But I think in particular for women, it's still considered off-label use in this country, but has now been FDA approved as a treatment for low libido, specifically in other countries such as Australia, right?
Yeah, so testosterone, we know works great for libido. We've got years and years of data. It's approved, as you said, in Australia by their FDA equivalent. And so it's infuriating, right? We have more than 26 plus options for my male patients to give them testosterone, and I have none that are FDA approved for my female patients, which is crazy. And actually, the story of men in testosterone is exactly the same story as women in testosterone. It works. It works in both. It works a little bit. It's not like, doesn't make you an nymphomaniac running around the house, but it improves libido. It improves mood a little bit. It gives you a more energy. Most of our data for women is around libido. But if you think Arnold Schwarzenegger and big muscles, like, testosterone does more than just raise your libido. But we have to I use male products, and I just dose them such that I give them female correct dosing, which is about a 10th. We need about a 10th of the amount of testosterone. And so I like FDA approved products. I'm always going to choose an FDA approved product if I have one. And so it's a big problem because the FDA had 5 years of data and $1 billion went into studying women and testosterone, and it showed it was safe. It showed it was effective. It wasn't dangerous. And the FDA said, we want 5 more years of data, which would be like another $1 billion, which no company is going to pay for it. Billionaire, if you're listening, please, let's do more studies. So the problem is it's like dead on arrival, right? There's no product. And so male testosterone, you need about 6 months of data and about $10 million to do a study. And so we've got unlimited products. We've got nasal gels, we've got patches, we've got creams, we've got injections, we've got oral pills that are out. We've got everything for our male patients. And it's so infuriating. I love testosterone in men. I love treating men with testosterone. I do so much good. It's so easy. I just had a patient just this week. He said, "Oh my God, Dr. Rubin, I have been seeing, a male urologist my entire life, and nobody has been able to figure this out the way that you have, because you actually listened to me. You spent time with me. You actually encouraged me to consider testosterone and explained why it might be helpful." And he is having the best life ever, right? He's interested. He gets better erections. He's so much happier. His retirement is now his best life, right? He's really enjoying himself. He said, none of my male doctors ever gave me the time of day with this problem. And so it's really fun treating testosterone in men. It's also really fun treating testosterone in women. I have women who come to see me and they say, geez, I came to see you for pain with sex, and yeah, it doesn't hurt anymore, but I didn't think I would want it again. I didn't think I would choose to have it again and think about it. That's what the testosterone does, which is so much fun. It's so much fun to see. And it doesn't happen right away. You have to tell patients it takes I would give it 3 to 6 months, because your body has to take it and the cream in, absorb it, and then make new proteins and do some stuff. So it takes some time, just like the vaginal estrogen takes some time. It doesn't work immediately.
Yeah. And as I understand it, with testosterone, topical testosterone for women, you want to make sure that you're not going at a super high level. There's a range that's considered a good target range to work toward for total testosterone, right? And so we're not trying to make people, crazy strong and build muscles and be way above what would be considered a normal range for 30 to 40-year-olds. But if we can get it back up to what would be considered normal in that age group, then that seems to really be all that it needs for the positive effect. I have a lot of people who come in who have talked to other types of providers who do tons and tons of hormone testing. Do you have any thoughts or comments for us about hormone testing? There's so many different kinds of tests out there. Do you are you familiar with some of these tests?
I think when it comes, I think there's really there's 2 sides to this. There are the snake oil salesmen who are trying to make money off of patients and selling them everything under the sun and some non-evidence-based testing and treatment options, which we can talk about. But there's the other side of the coin, which is the majority of modern medicine, which ignores and gaslights women completely and does absolutely nothing for them and tells them that they just need to suck it up and just do some more yoga and do some more deep breathing, and they do nothing. And then there are a few of us in the middle, which I like to say the evidence-based few, and it is a few. And this is the infuriating thing, is there's a few of us who really know the literature, know the data, know that hormones are beneficial, but also really look to the data and use FDA-approved products and use, and are a little bit more mindful about what's out there. And so even that ranges a little bit into the more conservative versus more aggressive. And I would argue that I am more aggressive because I am aggressively wanting people to have good quality of life. And so I'm willing to push some evidence when if somebody says, my body, my choice, this is what I want to try, and we talk risks and benefits, then I'm okay with, tinkering a little bit. But I think the problem comes when you have people who are making money off of supplements or pellets or saliva testing, where you're paying thousands of dollars for testing that's not quite evidence-based yet. And so that's what I tell patients. I say, listen, it may be that they're onto something here, but if these companies are so sure of their products, if they're so sure that they're right, then they should be forced to do the testing and the rigorous evidence and publishing so that the community, like the evidence-based community, like agrees with them, right? Because science is constantly expanding. So if you think pellets are the way to go, and we have an FDA-approved pellet for men, it's a testosterone pellet that works for men. It's called Testopel. Works great. Mm-hmm. If you could study, if you think pellets are the greatest thing in the world for women, do the studies, do the regulatory process, like make it, show me that it works, that it's safe, and I'll prescribe it, right? I'll do it. But they would rather make the billions of dollars and not do those things because they're going to make money either way. And that's the part that frustrates me, is that women are not holding science, like they're not taking these companies and saying, no, I want a higher standard of care for my health. I want the evidence, and I want you to do that, do that evidence, because, all these supplements and these Instagram ads and all these things to, take this, maca root and it's absolutely going to help your sexual health. Well, wait a minute here. The maca root company doesn't even have to put maca root in it. They can just put the bottle that says maca root, and they could just put licorice in, and just like, you don't know any different, and they could charge you $50, and like no one's holding them accountable. And that's where my blood boils, is that people are being taken advantage of. Does that make sense? So I'm, for all those people out there who are doing pellets or who have done these saliva tests, I'm not telling you you're wrong. I'm just telling you, have a higher standard of evidence and really, look at where the studies go. These are not journal, if they're studying it, the New England Journal of Medicine does not publish on hormone saliva tests, right? And so that's really the key there, is now, is science going to evolve? And could one day saliva testing be the standard of care? Absolutely. But they should have to do the work.
Yeah. Yeah, no, I agree with you. And I think it's really difficult to tease out, what's good medicine and what isn't. And it's really important to search out and talk to people who have been trained to do these things, because
you can't blame patients, because these people have really, really good marketing skills, and they say words that sound right, and they're very convincing, and it's shiny. There is a promise of the holy grail on the other side. And it's we see it on Men's Health all the time, and all these ads for shock your penis, give us thousands of dollars, we'll do shock waves on your penis that will cure your penis. And they're targeting these men with high blood pressure and diabetes and vascular disease that are never going to get perfect erections, no matter how many thousands of dollars they invest in these shockwave machines. So there's a lot of predatory advertising out there, and it's very unfortunate.
Yeah. So let's switch gears a little bit. I know that you work in conjunction with a number of different specialists when you're doing your best work, because there are so many different angles to come at sexual health. I wanted to take a couple minutes and just talk a little bit about pelvic floor physical therapy, because I think this is something that people really just don't necessarily know a ton about. So tell us what we need to know about pelvic floor physical therapy.
My favorite humans on earth are pelvic floor physical therapists. I think there's a misnomer among, especially women's health, men's health too a little bit, but definitely women's health, that your gynecologist knows everything and can do everything. It's totally unfair, right? It is totally unfair to expect your gynecologist to know everything from birth to grave, whether it's cancer, whether it's urinary issues, whether it's sexual health issues, like all the things, emergency surgery, babies, delivery, breastfeeding, like, no, they get 4 years of training. And like, there is literally, I know, Dr. West, you're married to a gynecologist. Like, there is no way on earth they can know everything, and they should not be held to that standard. That's actually misogyny, that they are held to that standard. And so we often work in a team, right? So this idea, like if you get a knee replacement, you do some physical therapy before your knee replacement. You go to the orthopod, they put the new knee in, and you go to physical therapy and you rehab the knee afterwards. Maybe you go see Dr. West to have your diabetes in control before your knee replacement, right? You work in a team. One of my colleagues so wonderfully described it as it's like a pit crew, right? You're like a Lamborghini and you need this fine pit crew to come and take care of you. So you can't always just go to the Honda dealership to like do your one-stop shopping. Like sometimes you need different people to come in and help you with a specific problem. So when you're dealing with anything that has to do with the pelvis or anything in general, you have to think, what is there? What exists in the pelvis? So if you're having pain with sex, for example, well, there is a pelvis, which is bone. There is muscle that surrounds that bone. And then you've got organs that kind of fit inside. And so the hormones affect the tissue, but the muscles are also affected by hormones, and they're affected by pain. So if you've ever put your hand on a hot stove, which obviously you don't do on purpose, right? If you put, and I always ask that, people who come to me with pain with sex, I say, well, how often do you put your hand on a hot stove? Well, they never do it, right? Because your body is going to pull away, right? And so that's what the pelvic floor does. So you've got this big bowl of muscle, and if it's in pain, it is going to try to get away from that pain. So if, say, this person wants penetration with their partner, or put a tampon in, or have a speculum exam, as it goes in, the pelvic floor is going to pull away. It's going to tighten. And so what pelvic floor physical therapists do, and they're magicians, they're absolutely like incredible unicorn magicians, is they train that pelvic floor, because it's not just about doing a Kegel and tightening all the muscles. Sometimes you have to relax the muscles. Sometimes you have to strengthen the muscles. And so they can help you with leakage. They can help you with urinary frequency and urgency. They can help with prolapse symptoms, and they can help significantly with painful intercourse. Now, they can't do it all because they don't always help with the hormonal piece and some of the other pieces that we can do, but we work extremely collaboratively, because I can't do it all. And I really explain to patients, that my magic, the only magic that I have, is I spend time with people. I spend time with people. I truly get to know them. I care deeply about them and their stories. And I find out what their goals are. And then I help to build them a team to maximize their goals. And that might mean, sending them to Eileen West for their concierge primary care, because my patients who go to Dr. West are the happiest patients in the world. It may be that they go to Dr. West and see a pelvic floor physical therapist. I may send them to a physiatrist to work on their back pain. I may send them to an right? Like, I'm going to work with different people. And that's the magic, is having a team. For me, being able to text Dr. West and say, hey, you just saw my patient so-and-so. What do you think of XYZ? That's the magic. And so that's what a pelvic floor physical therapist does. They're incredible. They will help, and they work with men as well. So they can help with pelvic pain in men, and urinary problems in men, and all sorts of sexual health issues as well in men. So it's an incredible field, and it's just advancing more and more every year.
Yeah, it's really exciting to me what pelvic floor physical therapy is capable of doing. And it's not just for the women either. I mean, it really, the men can benefit just as much as the women with certain, pain that's, goes from the waist to the thigh. I mean, there are a lot of structures in there that sometimes need a little bit of help just to get back to normal.
And it's also a lot of back pain. I think it's really important to say, like, we understand that if you have sciatica, right, it's leg pain, but it's not coming from the leg. It's coming from the back, right? You could put all the creams and lotions on your leg. It's not going to fix the problem because it's coming from the back. Well, we see a lot of penis pain, vulvar pain, clitoral pain, pelvic pain, that's actually probably not coming from the pelvis itself, but it's coming from the nerves that come from the back. And I think that advancing that understanding, and unfortunately, the back doctors are not talking about vulvas and penises. They're just not. And the problem is, the penis doctors, we are not taught about the hips and the lower back and what to do about that. So there's a lot of fragmentation in our training. And actually, it's the pelvic floor physical therapists that really bring that all together. And that's why they're so useful to have on speed dial. And
That's
we're
really
very lucky. We are very lucky in this area, in the Washington, D.C. area, because we have the best pelvic floor physical therapists. They are so good. The ones in Virginia by you are absolutely incredible. And it is, we are extremely, it's so good that I can just ask a patient where they live, and then I can like get them the Rolls Royce of pelvic floor physical therapists, like a couple miles from their house. Like, it's incredible.
Yeah, it's been really, really wonderful to see. I remember we lived in the Midwest, and when my husband was starting up his pelvic floor evaluation center at the University of Oklahoma, he was the only urogynecologist for 5 states. And he was also the first one to introduce the concept of pelvic floor physical therapy as part of his center. And it was just a shock to people to realize that this actually took place and how much help it was. Yeah. So they were working regularly with physical therapists in no time after they finally got things up and running. So it was really great. So.
And so I have a question. Can I ask you a question? You know,
yeah,
as you going through being an internist and getting sexual, you know, how has your practice changed through the years of as you've become more and more interested in menopause care, in sexual health care? How have you seen your practice change, and also your ability to talk about this with patients? Because it's not something that's always easy or natural to do in a quick, you know, primary care visit.
Right. Well, and like you, I have the advantage of a little bit more time now in my office visits, which makes a huge difference, because we really can start at the beginning and work our way through a series of questions. So I usually start with the North American Menopause Women's Consultation, you know, form. They've got a form for menopause consults, which I really love, because it's got very detailed questions, and a lot of them have been, you know, they're standardized, they're screening tests, screening questions that have been asked of many, many, many people and have been shown to have beneficial results when you get the answers. And so I think the big thing is just comfort level with it. It wasn't until I really started going to NAMS meetings regularly and talking to other people, other providers who do this, that I realized that, yeah, we really should, all primary care doctors should be comfortable doing this. It's so important. It's such an integral part of a person's life. You know, yes, we can talk to them about exercise. We can talk to them about not drinking too much. We can talk to them about not smoking. We can talk to them about how to lose weight. But overall health, I mean, sex is good for your health in so many ways.
Which is so interesting. It was actually at the NAMS conference that I thought this was very interesting, that, you know, I thought it was a very interesting point. One of the speakers said, she said, why, you know, as doctors, when we're taught to ask about sexual health care, it's in the vices section of the social history, where you're getting a social history. You're saying, do you smoke? Do you drink? Do you do drugs? Men, women, or both? Right. Like that sex is dangerous and bad and should always be looked at in sort of the vices category. And it was like, oh, that doesn't make any sense. Why is it? Why do we do that? Why are we taught to do that?
So we moved it over to the gynecology section, and in our, you know, with the male patients, when we're talking about prostate stuff, that's when all of that conversation starts. So, and it's really. The more I do it, the more comfortable I am with it, because I really have started to become familiar with what treatment strategies are available. And also I've started to see it really work. And that, I think, just makes me want to mention it more. I mean, I have very few patients who sooner or later don't want to bring it up. They, you know, most of the time, if asked about it, they will elaborate. Maybe not immediately at the very first time that the question is asked, but if you ask it just as a normal part of you know, a doctor's office visit, then it starts to become normal for people to talk about it. And it's just really, really helpful, I think, for people all around. So, yeah, I have... I really am very happy to be able to include that in the overall picture.
I wish I could say all primary care doctors were this good and able to talk about this. You know, I've certainly never been asked by, you know, I think most people I ask all the time when I'm lecturing to students, and has a doctor ever asked you about your sexual health? Have they ever shown interest. And so if you have a problem with your clitoris, who do you go see? Who's the doctor who takes care of you? And that's a big problem.
Right. And I think primary care physicians are, to be fair, they've got a lot of ground to cover, and there's so
Absolutely.
many topics and so many things to consider, and so many, they just don't want to leave really vital things on the table. But it's just, it opens up a whole new conversation that usually takes a little time. It takes a while for the patient to get comfortable talking about it, and for the doctor to understand what to do with the information that they hear. But it's I can't imagine not doing it now. So, and that's I think is wonderful, and I really do love that we're able to share this with other physicians. So if you are a physician out there hearing this and you want to learn more about these things, we have lots of ways to learn about it, and I would be very happy to point you in the right direction. So
yes, ISWISH, the International Society for the Study of Women's Sexual Health, is just an excellent, we have an excellent fall course, which is close to selling out already. And it's not even until, I think, November. It's in Scottsdale. And then it's just an incredible group of people where we're constantly doing trainings in women's sexual health.
Terrific. What else do we need to know? Are there other topics that we haven't hit on for sexual health? Other things that you think people ought to know about?
I think one of the things that we really need to cover is fun, the fun part of sexual health. I think oftentimes people think of sex as a chore. They're having their mercy sex, their duty sex. And I really like to remind people, like, you don't order the same dessert every time you go to a restaurant, right? You don't go on the same vacations every time you go on vacation. You certainly don't watch the exact same TV show every day for your entire life. You don't do it. You mix it up. You try new things. You try out new genres of books. You do different things to stimulate your, pleasure palette a little bit. And for some reason, sex is this thing that people get into this habit of just doing it in the same way, in the same position, in the same sort of, even in the same dance, the silent dance, right? Ooh, he held my hand and then I looked a certain way and then I made a comment and then we knew it was going to just happen. And so then it just started to happen and then we didn't talk about it. We don't talk about it before. We don't talk about it during. We don't talk about it after. What world are we living in, right? Anything you do is like, think about when you're successful at work, you plan an event, you have an event, you talk about the event afterwards. What went well? What could go well next time? What could we do better? How can we make this more fun? And sex is not, that does never happens when it comes to sex. And so I think couples are often more comfortable talking about constipation and diarrhea, but they don't even know if their partner masturbates and has orgasms. The word masturbation makes us also, squirrely and squirmy. And so we don't have these conversations because these private parts are even private to us while we're experiencing them, and where our own private parts we don't even know what's doing what, and it's kind of a no man's land down there. And so that's what we try to change. We try to educate people to understand their body parts, how they work, how we can make them work better. And so I'm a big believer in again, just thinking of sex as playtime and fun. And so maybe it's adding technology. Sex tech is incredible now compared to how it used to be. There are so many fun devices out there. In fact, our YouTube channel, we have short videos of different devices just that patients can start to look at them without judgment and say, that one looks kind of nice. Honey, what do you think of this one? And realize that devices, sex technology is just fun playtime, right? These are fun things that you can add to make sex more fun, more enjoyable. Orgasm is just a reflex. So can you make that reflex happen more easily, more powerfully if you use something that vibrates or something that stimulates? And there is so much cool technology out there that does that. And so it doesn't mean your partner's not good at your buttons or doesn't know you. It's, hey, can I find new ways to have pleasure and new ways to enjoy each other? And so there's great devices for couples. There's devices for men. There's devices for women. There's devices for couples of two women and couples of two men. And there's so many fun things out there. And there's new technology happening constantly, which is really fun when you're a sex doctor and everyone sends you all their newest technology, which is really fun as well. So check out our YouTube channel because we're constantly adding new devices and new ways to experience pleasure. And that should be fun. It shouldn't be like, oh, I can never bring this up to my partner because they would be mortified, or I'd hurt that person's feelings. I would argue, why can't you present it as, hey, let's go on a new vacation. Let's try something new. Let's have some fun, as opposed to, you're not good at this. It's, hey, what else can we do that's even more fun? And I think having those conversations is really, really important. So I love talking to patients about devices and bringing devices up into the conversation as early as possible.
Mm-hmm. Emphasizing the fun. That's really wonderful. Well, no, it's a special relationship, a special activity, right? There's not much else that, can bring you that close to somebody, but also just really, bring pleasure in a healthy, good way. So it's really wonderful. I think that's a nice way to end.
I love it. Thank you so much for having me. This was so much fun.
Thank you. And I seem to be having some problems seeing our comments today. So I'm really sorry if someone has gone in and asked questions that we have not specifically addressed. You can leave us the question and we'll circle back around and get your questions answered. But I'm just not able to see public comments or leave a comment in the public comments section right at this moment. My technology is not cooperating. But reach out to us. We're happy to address any and all questions as they come up. So
thank you so much. Thanks for having me, Dr. West.
All right. Yeah. Thanks so much, Dr. Rubin. It's wonderful to talk with you and I really appreciate it. And we'll see you soon.
Bye-bye.
Take care.